everyone. I am Dr. Naman Goyal from KIMS Institute of Medical Science, Bhubaneswar, and my topic is Imaging Insights into Adnexal Torsion, CT and MRI Findings. Introduction. Adnexal torsion represents a relatively uncommon but clinically significant etiology of acute lower abdominal pain in women and often poses a diagnostic challenge due to its overlap with other acute abdominal disorders. The condition should be considered as a differential diagnosis in patients presenting with an ovarian mass in an appropriate clinical context. In majority of the cases, adnexal torsion is associated with an ipsilateral ovarian cyst or neoplasm. Nevertheless, it may also arise in morphologically normal ovaries and particularly in pediatric populations. When torsion is complete and remains unrecognized or untreated, hemorrhaging infarction of the affected ovary can ensue, potentially progressing to peritonitis and in severe cases mortality. Prompt recognition of adnexal torsion is essential as timely intervention can prevent permanent ischemic injury to the adnexa and offers the possibility of ovary preserving surgery, particularly in young women. Despite this, the clinical establishing the diagnosis can be difficult because the clinical features, laboratory results, and imaging appearances are either non-specific and may overlap with other acute gynecological or abdominal conditions. Grayscale ultrasonography combined with Doppler assessment is generally the initial imaging technique of choice and can demonstrate characteristic changes. However, CT and MRI can provide additional diagnostic value, especially in atypical or subacute cases where ultrasound findings are inconclusive. Aims and objectives: to identify both frequently observed and less common CT and MR imaging characteristics of adnexal torsion, to describe the characteristic imaging appearance of hemorrhagic infarction as a complication of adnexal torsion. Materials and methods: study samples. 25 subjects with acute abdominal pain were studied. Study type: retrospectively reviewed the clinical findings CT and MR imaging in 25 patients with surgically proven adnexal torsion. Method: different imaging modalities were performed using G-evolution ultrasound machine, 64-slice CT machine, and 1.5 Tesla MRI machine. Results: in our series, the most frequent CT and MR imaging features of adnexal torsion were tubal thickening, observed in 84% of patients, smooth mural thickening of twisted ovarian lesion in 76%, presence of ascites in 64%, deviation of uterus towards affected sites in 36%. Less frequently were hemorrhage within the thickened tube 16%, hemorrhage inside the adnexal lesion 8%, and hemoperitoneum in 8%. Tube thickening significantly thickened in 21 of 25 patients. At CT, the thickened tube manifested as an amorphous or tubular mass-like structure in 15 cases and had a target-like appearance in 2 cases. At axial CT and MR imaging, it was seen between the twisted adnexal mass and uterus. In 6 cases, the thickened tube extended through the adnexal mass, partially covering the periphery of the mass. In 4 cases, it appeared on sagittal MR images as a protrusion on the twisted side continuous with the uterus, whereas in 2 cases, the thickened tube was detected on axial MR images. Smooth mass wall thickening. Adnexal masses with a maximum diameter of 5 to 19 cm were detected on the twisted side in all cases. The twisted adnexal mass was cystic with or without fat in 21 patients, mixed cystic and solid in 2 patients, and mainly solid in 2 patients. In 23 patients with a twisted cystic ovarian mass, we were able to measure the cyst wall, which proved to be thickened in 19 cases. All 19 cases demonstrated smooth wall thickening without evidence of irregularity or nodularity. Concentric wall thickening was noted in 6 patients and eccentric wall thickening in 13 patients. Eccentric wall thickening of the adnexal mass converging on the thickened tube was noted only in patients with hemorrhagic infarction. The wall of the twisted adnexal mass had an average thickness of 10 mm in patients with hemorrhagic infarction and of 3 mm in those without hemorrhagic infarction. Hemorrhage within the mass was noted in 2 patients with hemorrhagic infarction and hemorrhage in the wall of cystic mass in 1 such patient. Ascites and uterine deviation. Ascites was present in 16 patients. A small amount of ascites was seen in 15 patients, and a moderate amount was seen in 1 patient with hemorrhagic infarction. Hemoperitoneum was present in 2 patients with adnexal torsion and hemorrhagic infarction. Deviation of the uterus to the side of the twisted ovarian mass was noted in 9 patients. Imaging findings. A statistically significant difference between the patient with torsion with hemorrhagic infarction and those without hemorrhagic infarction was seen only in terms of eccentric wall thickening and wall thickness of the adnexal cystic mass. Although only a small number of patients were included in our study, among the 5 patients who underwent unenhanced CT, hemorrhage in the fallopian tube was present in 3. Among the 6 patients who underwent MRI imaging, hemorrhage in the tube was present in 1 and hemorrhage in the wall of the cystic mass was present in none. All 4 patients were with hemorrhagic tube had adnexal torsion with hemorrhagic infarction. In the patient with twisted ovarian serous cystadenoma resulting in hemorrhagic infarction, lack of enhancement in the multiple internal septa of the tumor was noted on contrast enhanced T1 weighted MRI images. Case 1. This is a case of torsion of serous cystadenoma of the left ovary with hemorrhagic infarction in a 50-year-old woman with a 2-day history of lower abdominal pain. This contrast enhanced CT scan shows a large unilocular cystic mass. Eccentric smooth wall thickening is noted along the left lateral margin of the mass. This contrast enhanced CT scan obtained shows an amorphous tubular structure, mass-like structure connecting the tumor and the uterus. This finding represents a twisted vascular pedicle. This is a case 2 showing a torsion of a left ovarian fibroma with hemorrhagic necrosis in a 30-year-old woman with 2-day history of lower abdominal pain. This shows a contrast-enhanced CT scan shows a well-circumcised solid mass in the right lower abdomen. This contrast-enhanced CT scan shows a wall structure abutting the inferior margin of the ovarian mass, a finding that represents a twisted vascular pedicle. A small amount of fluid is also noted in the pelvic cavity. This is a case 3 showing a torsion of a benign right ovarian cyst with hemorrhagic infarction in a 6-year-old girl with a 2-month history of intermittent lower abdominal pain. Axial T2 weighted MR images shows a thin-walled unilocular cyst with internal heterogeneous signal intensity. A twisted pedicle is also noted along the anterior aspect of the cystic mass. Axial T1 weighted MR images shows an intermediate signal intensity with hyperintense wall, a finding that suggests hemorrhage in the wall. Case 4 shows a torsion of a left ovarian dermoid cyst with hemorrhagic infarction in a 57-year-old woman. An enhanced CT scan shows a large mass with flat fluid level and focal wall calcification. Note also the ill-defined tubular structure adhering to the cyst wall with an attenuation about 64 suggesting of tubal hemorrhage. This unenhanced CT scan shows the uterus is deviated to the twisted side and the hazy fatty infiltration and the twisted tumor and fallopian tube. The case 5 shows a torsion of a right ovarian cyst with hemorrhagic infarction in a 40-year-old woman. This axial T2 weighted and T1 weighted MR images shows an elongated mass-like pedicle in the posterior-caudal portion of a cystic mass. Focal high intensity, also noted in T1 weighted images, suggests that a hemorrhagic right ovarian fallopian tube. So conclusion. Identification of a tubal thickening and smooth mural wall thickening of an adnexal cystic lesion on CT or MR imaging can provide valuable clues for diagnosing ovarian torsion. Sagittal MR images in particular may better demonstrate a thickened tube which typically appears as a tubular projection on the affected side. Additional radiological indicators suggest a hemorrhagic infarction secondary to torsion include asymmetric smooth mural wall thickening greater than 10 mm in a cystic ovarian lesion, often converging towards the thickened tube, absence of contrast enhancement within the solid tube or the thickened cyst wall, evidence of hemorrhage within the tube or the twisted ovarian lesion itself, and associated hemoperitoneum. So these are my references. Thank you.